cardiovascular disease. Nowadays, the cardiovascular disease is the number one killer disease of adults, and it's the main thing. The early recognition is very difficult in some of the cases, which leads to cardiac emergencies. So, cardiac emergencies and symptoms are one of the most common reasons for the patient attendance in any emergencies situation. So anatomy and physiology, if you're seeing, the heart has two chambers. So right side of the heart and left side of the heart divided by septum, and right atrium and right ventricle, left atrium and left ventricle. And the right atrium, usually it will receive the impure blood from the peripheral system, and from the right atrium, the blood will be pure blood will be entering into the right ventricle through the tricuspid valve. From the right ventricle, the blood will be pumping to the lungs through the pulmonary artery for the oxygenation, and oxygenated blood will be taken by the pulmonary vein, fourth pulmonary vein, and it will be coming back to left atrium, and from the left atrium through the mitral valve, it will be entering into the left ventricle, and from the left ventricle through aorta, the blood will be supplied to all parts of the body. And the various cardiac emergencies are considered as: the first one is acute myocardial infarction, heart failure, third sudden cardiac death, cardiac tamponade, and hypertensive emergencies and dyspneas. So let's see first what is myocardial infarction. So the myocardial infarction, also we will call it as heart attack. It is used anonymously, and the MI is defined as cell death. So there is a greater difference between angina pectoris and myocardial infarction. Angina pectoris is decreased blood supply to the myocardium, but in myocardial infarction there will be a complete cut of blood supply to myocardium. And myocardial infarction occurs as a result of sustained ischemia. So initially, it will be started as ischemia in the myocardium, and the people, those are not aware, they are asymptomatic, they used to neglect the thing. So that's what finally it will go as a necrosis or complete death of myocardial tissue. The types, so the types of MI depends upon the ST elevation, and overall it's divided into ST elevation MI and non-ST elevation MI. And infarctions are usually described based on location of damage, that is anterior wall MI or inferior wall MI or posterior wall MI or lateral wall MI. So the causes of the cardiac emergencies, that is myocardial infarction, main thing is atherosclerosis, that is accumulation of the platelets in the myocardium, and 90% of all acute MI are secondary to thrombus formation. So initially, the coronary artery will be occluded with the plate formation or a thrombus formation. And the three mechanisms that are primarily responsible for acute reduction of oxygen. So automatically, if there is a vessel, there is an occlusion or narrowed of an artery, automatically there will be an oxygen supply also will be diminished. So the main thing that is leads to decreased oxygen delivery, that is coronary artery thrombosis, plate fissure or hemorrhage, or coronary artery spasm. So let us see the pathophysiology of MI. Due to risk factors, that is coronary atherosclerotic heart disease or coronary thrombus and embolism, there will be decreased blood flow to coronary artery. So automatically there will be a decreased myocardial oxygen supply and ischemia. As a result, there will be decreased myocardial contractility and cardiac output. And finally, there will be stimulation of baroreceptor and sympathetic receptors. And as a result, there will be an increased myocardial contractility, so there will be an increased heart rate, so diastolic filling will be decreased due to the narrowing of the artery, so the patient will go for prolonged ischemia. And finally, if it's the prolonged ischemia, it exists for a long time, it leads to cellular damage and necrosis of cardiac muscle. Finally, it leads to myocardial infarction. perfusion, always we have to ask the location of the chest pain. The chest pain will be starting from the upper chest, and it will be radiating to substernal and neck and jaw, and it may radiate to left upper arm and epigastric region, and again it will be radiating to neck and jaw, left shoulder, and intrascapular, and associated with the nausea, vomiting, and diaphoresis, that is increased sweating also will be noted. Diagnosis, so we will be collecting the thorough history. Mainly we should ask any family history of cardiac disease, and we have to do the physical examination and 20 electrocardiography and cardiac enzymes like CPK, MB, CK, and troponin. And you should take the chest X-ray in order to see the size of the heart, and like serum cardiac markers, that the CPK and CKMB, echocardiography, scintigraphy, and CT angiography. And here you can see that ST elevation and ST depression. So usually when the patient developing the chest pain, from that time onwards till 6 hours the ST elevation will be there, and after 6 hours the elevation will be started going into depression. So here you can see that ST depression, after ST depression there may be a formation of Q wave. So management, so the first goal of the management for MI patient is revascularization and reperfusion using fibrinolysis or primary angioplasty. So our first focus is to revascularize the vessel which is blocked, and oxygen should be administered. So automatically when there is a plaque or obstruction of blood vessels, there will be an oxygen carrying capacity also will be diminished. So oxygen should be administered 90% in order to prevent respiratory distress. And nitroglycerin, so vasodilator and reduce myocardial preload and afterload. And beta blockers should be given. Beta blocker, that is metoprolol, after checking the heart rate, and calcium channel blocker, AC inhibitors, antiplatelet therapy, and anticoagulants. And with collaborative management of MI reperfusion. So the reperfusion mainly will be done within 6 hours of the fresh MI. So that is thrombolytic therapy, streptokinase or urokinase, and or percutaneous coronary intervention we can do. And for fibrinolytic therapy, so the main focus of fibrinolytic therapy is to help to improve the coronary blood flow. So that will be initiated within 30 minutes to 1 hour, and not interventional. So it will be done, that the fibrinolytic therapy will be done in the coronary care unit, and that is medication for fibrinolytic therapy is recombinant plasminogen activator, that is retin-place or tissue plasminogen activator, that is active place. So that is the pre-fibrinolytic therapy care, post-fibrinolytic therapy care. So usually before uh, starting the antiplatelet, usually we will be checking the patient hemodynamic status and bleeding time, clotting time, because there is a chance after starting the this thrombolysis therapy, there may be a chance of bleeding, and there may be a sudden drop in blood pressure. So continuously we have to monitor the blood pressure and the heart rate throughout the therapy. So collaborative management, emergency perfusion therapy, that is percutaneous transmural coronary angioplasty. So here you can see the first diagram where exactly the plaque is formed. There they will be placing the stent, balloon tip stent. So once the stent is, the balloon tip stent is adhered in the platelet area, we will be inflating. So once we are inflating, what will happen? It will be started, the plaque started dissolving, and the vessel will be getting enough space for the permanent blood flow. And here the coronary stent you can see. So the first picture you can see, that is the deflated stent, and the second one we are inflating along with the balloon. And once it is adhered in the vessel, we are removing the balloon. Complication of MI, dysarrhythmias, 80% of the patient may go for dysarrhythmias, ventricular aneurysm, ventricular ventricular septal defect, and there may be a chance of pulmonary edema, and even heart failure, cardiogenic shock, papillary muscle dysfunction, and inflammatory heart disease, that is pericarditis and cardiac tamponade. List of nursing diagnoses: ineffective cardiac tissue perfusion related to coronary artery occlusion, decreased cardiac output related to impaired contractility, acute chest pain related to decreased oxygen supply to myocardial tissue, activity intolerance related to insufficient oxygenation to perform activities of daily living, anxiety related to chest pain and threatening environment, ineffective coping related to threats to self-esteem and lack of significant support system, risk for injury related to dissolution of protective cords. Clinical manifestation of heart failure. So it is two types: the heart failure, left ventricular failure and right ventricular failure. So in case the patient has left ventricular failure, there may be tachypnea, tachycardia, cough, crackles, hemoptysis, cyanosis, pulmonary edema, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. And in right ventricular failure, peripheral edema, hepatomegaly, splenomegaly, ascites, jugular vein distension, increased cerebral venous pressure, central venous pressure, pulmonary hypertension, anorexia, weakness, and indigestion. So what is the treatment for heart failure? So the main thing, we have to stabilize the patient, identify the underlying cause. Immediately whenever we are receiving the patient with congestive heart failure, we will make the patient to lie in an upright position, that is Fowler's position, and we have to start the oxygen. Nursing management of heart failure. The first one, optimize cardiopulmonary function. So here, when you are optimizing the cardiopulmonary function, we have to auscultate breath sound, administer oxygen, diuretics or vasodilators, and prepare for EP intubation and mechanical ventilation, and we have to check the weight daily. Promote rest, restrict activity and prescribe bed rest, elevate the head end of bed, monitor vital signs and activity intolerance. And pharmacologic therapy, administer diuretics, positive inotropes, vasodilators, and we should monitor the hemodynamic parameters and provide nutrition. So what is sudden cardiac death? Sudden cardiac death occur in patients with a pre-existing ventricular dysfunction secondary to multivessel cardiac disease with or without history of MI. The risk factors: ventricular tachycardia, ventricular fibrillation, dilated cardiomyopathy, aortic stenosis, atrioventricular block. Management: mainly we will be giving antidyspneic drugs or internal cardioverter defibrillation. So what is cardiac tamponade? You can see there is some fluid buildup within the pericardial sac. So excess amount of fluid will be accumulated in the pericardial sac. So what will happen? It will be preventing the pumping effectivity. So the patient will be getting the heart failure. So most of the patients, those who are having the heart failure, they are prone to develop cardiac tamponade. So the pericardial layers, mainly visceral layer, parietal layer, and fibrous pericardium. So the causes of cardiac tamponade, the main cause, that is maybe caused due to bacterial or myobacterial, fungal, hemopericardium, that is traumatic, iatrogenic or aortic dissection, HIV virus or uremia, or the patient those are undergoing dialysis or any malignancy in the body. The pathophysiology: accumulation of fluid under high pressure. It will be compressing the cardiac chamber and it will impair the diastolic filling of both ventricles. So there may be a chance of decreased stroke volume or increased venous pressure. Decreased stroke volume leads to decreased cardiac output, and increased venous pressure causes systemic and pulmonary congestion. And finally, it will be leads to decreased cardiac output, systemic congestion, and pulmonary congestion. So decreased cardiac output automatically leads to hypotension, shock, and reflex tachycardia. And in systemic congestion leads to increased jugular venous pressure. There may be a cause of increased liver size and ascites, accumulation of fluid, and peripheral edema, and pulmonary congestion will be causing real sound we will be hearing in the during auscultation. So the clinical manifestation, mainly the patient may be having the complaint of tachycardia, and the cardiac tamponade mainly we will see the in X-ray, echo we can see the pericardial effusion, accumulation of fluid in the pericardial sac we can see, and there may be a chance of ventricular wall prolapse, and even the ECG there may be a tall T wave you can see, and mainly the cardiac tamponade will be assessed by bedside. The bedside, mainly we will see the three symptoms, that is hypotension, jugulovenous distension, muffled heart sound. These are the three signs we can see in the bedside. And even you can see the tension pneumothorax, that is hypotension, jugulovenous distension, and absent blood sound. Tachycardia, and that is pericardium, precardia with both inspection and palpation, and there may be a rump and peripheral cyanosis. Here you can see the normal shaped heart and the globular shaped heart from pericardial fluid, excess amount of pericardial fluid in the sac. Medical management, oxygenation, increasing the volume may help patients with a hypovolemic shock, bed rest and leg elevation. Inotropic drugs like injection dobutamine will be diluted in normal saline or 5% estrus. And mechanical ventilation with a positive airway pressure should be avoided. With the tamponade, mainly with the PEEP support will not be given because it will be further decrease the cardiac output. Surgical management, pericardiocentesis, the treatment of cardiac tamponade is the drainage of the pericardial contents, preferably by needle paracentesis, with the use of echocardiography or another type of imaging such as fluoroscopy or computer tomography. So what is hypertensive emergencies? The hypertensive emergency or crisis with acute end organ ischemia. So hypertensive urgency, patients with poorly controlled hypertension or even the mild hypertension patient also go for hypertensive emergency, and transient hypertension. So normally we know the hypertension is the elevation of blood pressure that is systolic above 130 and diastolic above 90 mm of Hg. And the hypertension, mainly we will be giving the treatment if the diastolic blood pressure is above 90. So the causes of hypertensive emergencies, there is no history of non-compliance to drug, may cause due to acute renal failure, central nervous system, any problem in the central nervous system, or even some drugs or tyramine containing foods or beverages, and even pregnancy-induced eclampsia. The clinical manifestation, patient may have headache, papillary edema, coma, or angina, myocardial infarction, chest pain, acute heart failure, hypertension, and any vascular surgery. So the diagnostic treatment, we have to check the BP in both arms, intra-aortic line monitoring, IABP line monitoring we can do, and we have to monitor the 12-lead ECG. Medical management, antihypertensive therapy, and we have to give vasodilators, short-acting beta blockers like betalol, esmolol, and IV, intravenous AC inhibitors, furosemide. And in hypertensive urgencies, we can prescribe calcium channel blocker like nifedipine orally, and even captopril, that is AC inhibitor, or even beta blocker. List of nursing diagnosis: altered cerebral tissue perfusion related to vasospasm or hemorrhage, altered myocardial tissue perfusion related to acute myocardial ischemia, anxiety related to threat to biological and social. So what is dysarrhythmia? So the dysarrhythmias present the emergency department as chest pain, breathlessness, palpitation, sweating, pre-syncope, syncope, and thromboembolic complications. Definition: an arrhythmia is an abnormality of rate, regularity, or site of origin of the cardiac impulse, or a disturbance in conduction that causes an abnormal sequence of activation. So there may be an irregular rhythm, you can see abnormal rate, conduction abnormality. So normal rhythm we will call it a sinus rhythm. So here the patient with the dysarrhythmias, the rhythm will be normal, and the normal heart rate is 60 to 100. So here you can see the dysarrhythmia. Either the heart rate will be above 100 or less than 60. Dysarrhythmias and acute MI. So myocardial infarction patients experience complications due to electrical dysfunction, which include bradycardia, bundle branch block, and heart block. And etiology, tissue ischemia, hypoxemia, metabolic derangements, and there may be chance of acid-base imbalance, electrolyte imbalance, cardiomyopathy, or even drugs. Treatment, we have to administer oxygen to reduce myocardial hypoxia, and IV lidocaine can be given bolus, and we should correct the electrolyte and acid-base imbalance. Diagnostic approaches, history and physical examination, ECG recording like Holter monitor, we can do treadmill test, transesophageal electrophysiology study, and invasive electrophysiology study. So what is ventricular tachycardia? Commonly we call as VT. A run of 3 or more premature ventricular contractions. So if there is 2 or more premature ventricular contraction, that is called a life-threatening disarrhythmia. Because why we are saying is it will be decreasing the cardiac output, and this ventricular tachycardia, if it's persisting for a long time, it may lead to ventricular fibrillation, and which is a lethal arrhythmia. So forms of ventricular tachycardia, it may be a monomorphic or polymorphic. Either it may be an abnormality of the one wave or multiple waves. So the clinical association, ventricular tachycardia may be associated with a myocardial infarction or coronary artery disease or electrolyte imbalance or cardiomyopathy, mitral valve collapse, long QT syndrome, drug toxicity, and CNS disorders. So ventricular tachycardia, ECG characteristics, the ventricular rate will be 150 to 250 beats per minute. Rhythm may be regular or irregular. AV dissociation may be present with the P wave occurring independently of the QRS complex, and with a duration of above 0.12. And ST wave will be in an opposite direction. R wave may be sometimes regular or sometimes irregular. And the clinical significance, ventricular tachycardia, sometimes the patient may be stable, and you can feel the pulse. Sometimes even the patient may have pulseless, and there may be a decreased cardiac output, which leads to hypotension, pulmonary edema, decreased blood flow, and we have to if we fail to monitor the patient may go for cardiopulmonary arrest. So ventricular tachycardia, identify the cause and treat. If pulse is present, IV procainamide, sotalol, amiodarone, or lidocaine can be given. Ventricular tachycardia without pulse, CPR should be given, started, and defibrillation also given along with vasopressors and antihystericals. What is ventricular fibrillation? Ventricular fibrillation is a severe derangement of the heart rhythm characterized on ECG by irregular waveform of various shapes. Ventricular fibrillation mainly occurs in acute MI, myocardial ischemia, and in chronic diseases such as heart failure and cardiomyopathy. Other clinical associations are accidental electric shock, hyperkalemia, that is increased potassium level, or due to any drug toxicity. And the ECG characteristics, here the heart rate we can't measure, rhythm will be irregular and chaotic, and the P wave we can't see the P wave because there may not be the contraction of the atrium will not be there, and the ventricle will be contracted independently. There will not be any regulation, and we can see the PR interval and QRS interval, we can't measure it. Ventricular fibrillation, most of the time the patient may be unresponsive, pulseless, and apneic, and if you are not treating, patient may die. Treatment immediately, we have to start CPR, advanced cardiac life support with use of defibrillation. So asystole, what is asystole? Represents the total absence of ventricular electrical activity. Occasionally P wave was seen, sometimes P wave was seen, sometimes it may be absent. Clinical association, result of advanced cardiac disease, conduction system disturbance, or end stage heart failure. Asystole, generally patient has a prolonged arrest and cannot be resuscitated. Treatment, acute cardiac life support, we can give along with the drug therapy, intubation, and we can insert the pacemaker. So what is pulseless electrical activity? Shortly we will say PEA. So it denotes that there is no mechanical activity of the ventricles and the patient will not be having pulse. So the patient will be hypolemia, hypoxemia, metabolic acidosis, hyperkalemia, hypothermia, drug overdose, cardiac tamponade, myocardial infarction, tension, pneumothorax, trauma, and pulmonary embolism. And here mainly we will start immediately. If you are seeing a patient with a pulseless electrical activity, immediately we have to start the CPR with the drug therapy, that is epinephrine, and intubation, and mainly we will start the atropine infusion. So coming into the conclusion, every patient diagnosed with life-threatening cardiac emergency like acute infarction, any syncope attack or heart failure or cardiac tamponade, dysarrhythmias and hypertensive emergency should receive emergency care like oxygenation, ventilator support, and appropriate pharmacotherapy. So it may lead to helps to save the life of the patient.